Welcome. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar about preparing your child for healthcare independence. Joining us today are Dr. Nick CaJacob and Dr. James Callaway. They are gastroenterologists at the University of Alabama at Birmingham. Dr. CaJacob is an associate professor of pediatrics and serves as the director of the Alabama Center for Eosinophilic Gastrointestinal Disorders. Dr. Callaway is an associate professor of medicine and holds a secondary appointment with the Department of ENT, is the second chief of gastroenterology at the Birmingham VA Medical Center, and the director of esophageal motility lab at the Kirkland Clinic of UAB Hospital. Welcome.
Thanks for having us.
Thank you, Jennifer. I'd like to start off with a warm thank you to the entire APFED organization on behalf of both Dr. Callaway and myself for the invitation to speak with all of you today on this important topic, and in particular to our host, Jennifer Roeder, who coordinated today's event. So with that, we'll go ahead and get started. Next slide, please. What we're going to be talking today is preparing your child for healthcare independence. This is really important as many patients are diagnosed in their childhood years, and we'll go through this transition, and it's an important handoff of care that has many players involved and a lot of important steps to consider to be successful. So briefly, our objectives today are to review the basics of both eosinophilic esophagitis and eosinophilic GI disorders in general. Know that we'll refer mostly to EOE based on the amount of data that's available to us from that aspect, but many of these same principles will apply beyond the spectrum of just EOE and into the other eosinophilic GI disorders. We'll introduce the concept of healthcare transitions, review some common barriers to healthcare transitions, and then really spend a lot of time discussing strategies to prepare for a successful transition to adult care. Next slide. Many of you on this webinar will be familiar with EOE and the non-EOE EGIDs, either being patients yourself or a caregiver for someone with these diagnoses. But briefly to review this, it's a chronic inflammatory disease characterized by immune dysregulation, typically driven by a type 2 immune response, with important factors like elevated cytokines and specific IL-4, 13, and 5, accumulation of eosinophils, which are the predominant cell type that's seen under the microscope histologically on biopsies, but also basophils, mast cells, and other immune-mediated cells, elevated levels of immunoglobulin G4 or IgG4, and epithelial barrier dysfunction. A core element that really underlies both treatment and transition planning in EOE is the chronic nature of this disease. This really necessitates a chronic care management strategy similar to other allergic disorders that people are familiar with, such as asthma and eczema, with important elements such as shared decision-making and repeated structured assessments over time. We'll touch on more of these elements as they relate to preparing for a successful transition of care throughout this talk. Next slide. So in order to diagnose EOE, there should be some clinical evidence of esophageal dysfunction, some signs or symptoms that point towards troubles when eating and swallowing specifically. It became very evident early in our understanding of EOE that esophageal dysfunction can present differently based on age. And so you can see here where infants and children can have more reflux-like symptoms, vomiting, nausea, abdominal pain, food refusal, or even failure to thrive, versus in adolescents and adults, you see more dysphagia or trouble swallowing, potentially food impactions, non-swallowing chest pain, and reflux-like symptoms. So this is definitely a challenging discrepancy, and it highlights the need for vigilance across the spectrum of ages in order to diagnose this appropriately. As a gastroenterologist, like Dr. Callaway or myself, is typically required at this point to perform an endoscopy in order to meet the criteria histologically of seeing that peak eosinophil counts greater than 15 per high power field. And so, as physicians, I think we often think of the diagnosis as the start of the journey for our patients with EOE, but we need to remember that there's often years of symptoms, with the average delay of diagnosis for EOE being approximately 3 years, and a wide variability with some people even waiting decades to get their diagnosis, and also a lifetime of lived experience and context that needed to be included in all aspects of management, including this transition planning that we're talking about today. And it's really my opinion that conveying this context is perhaps the most challenging aspect of transition of care, because these details are not really easily captured in the medical documentation or the results that are mainstays of transition planning that we'll talk about. Next slide. So briefly talking about treatment options that are currently available for EOE, understanding that these change with time. We'll start with diet, the 3Ds. Diet interventions have been there from the very beginning, and they vary widely from elemental diets to empiric elimination diets and also targeted elimination diets. The drugs we think of, medications are commonly prescribed to manage EOE. They include things like proton pump inhibitors or PPIs, which are thought to help in EOE more due to anti-inflammatory mechanisms than their known acid blocking properties. There's also the topical steroid approach, with swallowed preparation coating the esophagus, either inhaled or a viscous slurry solution. And finally, biologic therapies that are now on the market, with dupilumab, or brand name Dupixent, being approved for EOE since May of 2022. There's really currently limited evidence on which treatment option is best for which individual patient. However, I have patients on all of these various options who are happy with their treatment plans. And from a transition of care standpoint, I really focus more on ensuring that whatever treatment we're on, it's stable. Our effectiveness is known among myself and the patient and the caregivers, and that really ensures a good, predictable handoff. And then lastly, from the treatment standpoint, once fibrosis is present, many patients will do well with dilation therapy, or periodically stretching out the esophagus with either bougies or balloons. And the good news for my side of things is that EOE is typically a slowly progressive issue that few of my pediatric patients will require dilation, but it's still an important aspect of transition planning that I incorporate, even when patients have not needed that in their pediatric course. And it's important to note here that really the treatment of EOE never ends. This is really a chronic disease, and it's a hard concept for children to understand, and even adults, that this doesn't just go away, that we need to continue to manage this over time, even if those management plans change with time. Next slide. I'm personally excited at the time of this webinar recording. The Winter Olympics are coming soon, but this is more of a Summer Olympic metaphor, and I think it works well in that the handing off of the baton in a track relay race is a good way of thinking about how we transition. There's numerous steps in the preparation, the execution of handing a baton off, and when it goes well, it looks effortless and beautiful. However, there are numerous places where things can get complicated and connections can be missed. And like in the metaphor, these challenges don't stop the race, but can be costly when one looks at how the transition affects the overall results. And so now we're going to go on to define what we mean by transitions of care in healthcare and some of the keys to ensuring a successful transition. Next slide. So this is a great definition from actually the EOE literature, that healthcare transitions are a purposeful, planned movement of adolescent and young adults with chronic physical and medical conditions from child-centered to adult-oriented healthcare systems, with the optimal goal of providing healthcare that is uninterrupted, that's important, coordinated, developmentally appropriate, we'll discuss this more, and physiologically sound, psychologically sound and comprehensive. So really kind of defining some of those important aspects and giving us a North Star to define our approach. Now, next slide, we'll break down a little bit further. So another way of defining healthcare transitions is to break the process down into some core elements. Those are seen here, thinking about transition of care policies and guidelines. How do we track and monitor the transition? How do we assess transition readiness? How do we make sure that the planning is adequate and clearly defined? Actually executing of the transfer of care, and then when the transfer is completed, how do we know that that is the case? And these come from a great organization called Got Transition. Their website, gottransition.org, has a lot of great resources that are focused on clinicians, patients, and caregivers that include some of these tools that we'll talk about, like the readiness assessments and toolkits. So I encourage you all to look at that website if you're in the midst of this transition phase of care and want to get a little further information and look at some of those resources yourself. So, it's not always obvious to me how this plan is being implemented, as it's often embedded in ways during routine clinical care that feel routine. And really that means it's going well. So for example, when I'm interacting with my adolescent patients, a lot of times I'll be creating eye contact with them and asking questions directly of them, more so than their caregivers when they're younger, in order to really kind of prompt them to understand that they're taking over some of those responsibilities. So just know that if you don't see all of these elements directly verbalized or obviously happening, doesn't mean that they're not happening either. Okay, so why does it matter? Why do we want to transition well? Next slide, please. Fortunately, even though EOE is a chronic disease, we don't have a lot of scary bad things that happen over the course of a lifetime of a patient with EOE. Malnutrition is extremely rare. Life expectancy is normal. However, EOE, we know, has a lot of implications related to a patient's quality of life. And because this is a chronic illness with progressive nature, we need to continually address the quality of life over time because that can change. And because EOE has impacts on eating, and eating as humans is one of the most important things that we do. We do it, typically 3 times a day. It's often the focus of social settings. It has a lot of impacts on our social lives and our psychosocial domains. And so I think it's inherently obvious to me and to my patients who I work with. But remember, sometimes people from the outside don't understand what it means to have EOE and how that can affect your quality of life. And really importantly, knowing that treatment works, that these things that we have available to us now can greatly impact quality of life, is important, because it's sad when I have patients who choose not to or fall off of their treatment plans, and then start to have impacts in their quality of life, and some of their social and psychological domains, where we're able to circle back and say, hey, let's try and re-engage and get back to what works in the treatment plan. Next slide, please. And then who, what, where, when, and how. These are the other questions that are important. So, the team, and it has to include the patient, usually includes a parent or a caregiver, can include a transition coordinator, pediatric provider, and adult provider. And it's a team approach. we need to ensure that there are um, uh, milestones that the team agrees on, an overall strategy, and sometimes depending on your resources locally, not all of these people will be available, or sometimes they'll take on multiple roles. So, for instance, oftentimes for us, the provider will take on the role of the transition coordinator. We'll talk about. Um, the general elements that are required for transition include flexible developmentally appropriate care. We know that each child and parent is different, and so this is not something that a one size fit all approach will work. Families and patients are at different levels in their ability and their journey in understanding what EOE is, what are the causes, how to manage it. And so because of this, we need to be flexible. It's typically initiated in early adolescence, but I will say also that it can be initiated earlier than that. I often, in my early school age kids, even 6, 7, 8 year olds, in that first clinical visit after diagnosis, will finish the visit with a single question for them. Hey, what's the name of the disease that we're talking about that we diagnosed that we're planning on treating? And oftentimes they come up with, and they're very excited that they know EOE. I give extra credit for those who can pronounce the full eosinophilic esophagitis, but it's really for me an establishing of, hey, this is important, that I want you to understand what's going on. This is your body in your journey that we're all kind of embarking on. We also know that giving increasing responsibility over time is really important. That's true of adolescents in general, but especially in the healthcare setting, there's many challenging things that we'll go over, including insurance coverage, medications, how to schedule appointments that are we should kind of give patients progressive responsibility, not just expect them to be able to do it all at once. And then, encouraging peer support, it can be really helpful, and having an involved support team and support system is really important. And that's, part of the APFED mission and something that they do really well. So I'm glad to have that as a resource that many of my patients can rely on. Next slide, please. This is just a quick look of what the physical differences of a pediatric versus adult care can be. And you see at Children's of Alabama, there's bright colors and a warm, inviting space. The Kirkland Clinic of UAB, it's beautiful and architecturally stunning, but is a stark contrast and can be a part of the transition that we need to anticipate and really make sure that our patients are aware of some of these contextual pieces that can happen. Next slide. So again, going over the essential elements, I think this is kind of a good list of the core things. Transition coordinator, knowing that may not actually be an individual person. There may be other folks that are involved in helping occupy that role. Some kind of milestone assessment, to make sure that there is readiness and folks are progressing along a continuity of how they're preparing for adult that transition to adult care. Education, both on the patient and parent side, and then provider education and engagement over time with how to do this well. Next slide. This is a little bit better, I think, diagram of some of the other hidden people that can be involved to make this this transition go better. So the transition care coordinator, again, resources provider. The electronic health record, I think, is really critical and becoming even more critical as many of the tools and the strategies that we use become embedded in the electronic health record. And we'll talk about that more as we move on. Telemedicine and how that incorporates into how we are able to provide care in appropriate ways. And then patient advocacy groups. So this is like APFED, and even this webinar today is a great example of how they can be promoting and striving to improve the quality of transition of care. Um, and social media ever present, how we get the messaging out there, how we make sure that people are able to access these resources appropriately. And then next slide. Um, so this is then the summary slide for all of how we put this together and how we make a game plan for transition. We're not going to go too in depth into this, but just know that this is kind of the map that we use to say, okay, what needs to happen when? So you can see early adolescent years, those 13, 15-year-olds were introducing the concept of transition that, hey, we're going to need to eventually get to the point where we're going to adult care providers. And then we're developing individualized care plans, introducing EOE specific pieces. And then really after that, it's thinking about how do we assess readiness and make that transition of care happen in late adolescence to adulthood. And then finally make sure that the continuity of care is there into adult. So with that, now I'm going to transition to Dr. Callaway to tell us a little bit more about the challenges commonly encountered in transitions of care and strategies to navigate them successfully.
Yeah, thank you, Nick. Very good summary of things so far. So I appreciate the commentary. So what I was going to talk about today are barriers that we do commonly encounter when it comes to transitioning of care. So I'm an adult gastroenterologist, so I'm picking up the baton from Nick as he is transitioning his patients over to my practice. And as he said, there's a difference between adult medicine and pediatric medicine that occurs not only in the physical buildings itself, but sometimes just in the way that care and the business. And again, they're going to be in a hospital in a building that has patients of all ages that are there. So it's not just pediatric patients they would be around even when they come for their very first visit. And so the barriers have been looked at. There have been studies that have looked at what are the common things that may occur in multiple different domains that we need to be thinking about, not only as providers, but also patients and their caregivers, and also systematic things. So next slide. These are those domains. So I'm going to talk about each of these individually, talk specifically about things that are more pertinent to the patient themselves, also parent or caregiver specific barriers, things that you guys may run into, and then things that we think about as providers that makes sometimes that transition more difficult, things that we have to think through. How do we do that well? Recognizing that each of these things do have, I want to say answers, but they have ways that we can get around them, or each barrier can be approached in a way that we can try to get around it or try to see what works best for each individual family and patient. And then some of the more tricky ones are the systematic barriers. So things that are embedded within the system that can make transitioning difficult. And sometimes that is things like the finances and insurance and things of that nature, which can make things tricky. So let's look at each of these individually. Next slide. So under the patient and parent specific barriers, one of the things that comes up is normal adolescent behavior. We know that rebellion, apathy, and just obtaining independence from parents can be a tricky thing, regardless if someone has a chronic illness or a chronic condition. And especially as you're maybe transitioning into adult medicine between 18 and 22, that is a very difficult time. We're discovering ourselves, independence outside of medical illnesses, but just discovering ourselves in general. And so that oftentimes can be a tricky thing to navigate, mainly because we want people to take our patients to take ownership of their condition, and that is just a thing that everyone runs into. We do know that adherence kind of worsens during adolescence and transition times as people are trying to figure out that independence. We try to avoid the word non-compliance because it sounds kind of bad, but we want people to be adhering to their treatment plan and kind of buying in as to what we're trying to do as a group. And that is, we want your quality of life, or we want a patient's quality of life to be improved. And buying into that and working and recognizing that adhering to that treatment plan is one of the common goals that we both have as providers and working with our patients and parents. Developmental challenges can occur because just the concept of chronic illnesses in general can be challenging, and that can add an extra hardship to growth, development, and coordination and coping with the concept of a chronic illness. Something that comes up is the kind of appropriate level of parental involvement. Nick mentioned scheduling, and that's something I really hadn't thought about much until he had made that comment. But typically our parents have always taken care of our schedule and help us get to our appointments. But if between 18 and 22, which is a common time that people are transitioning over, all of a sudden you may be in control of your own schedule and whatnot, and that may be a new concept of something that a patient has never thought about before, or even not even have a great calendar system to make that happen. So, but at the same time, we want patients to again need to figure out what is that level of independence going to look like. And that definitely varies family to family on how much parental involvement is needed. Sometimes a lot of parental involvement is necessary to make not only transitioning work well, but even into adulthood to allow for good care to continue. And then sometimes that parental involvement may be less necessary. We'll see different levels of independence in each of our patient, parent, and caregiver relationships. And the last thing is that comfort with changing providers, which is tricky because especially if you've had a very good and meaningful relationship with your pediatric provider, all of a sudden you're switching to a new provider, a new face, and what does that look like, and what is that relationship going to be? And there can be a certain amount of anxiety associated with that is going to require, it may require us to develop rapport and develop that new relationship. That is actually one of the harder batons to take on and to pass is navigating that relationship. Right, next slide. On our level, on the provider specific barriers, there's not a lot of great literature out there about what does transitioning care look like well. There's only a few articles that really try to address this, and there's even fewer in the world of eosinophilic esophagitis and in EGIDs in general. There's not a lot of literature there, but we do know that we want to work on this, and so there are more groups and advocacy groups that are looking at how do we make this transition well. So not only is the education needed for parents and caregivers, but it's also for providers as we try to figure out and work with our pediatric colleagues on how do we make that transition well. Insufficient communication is a big barrier that does come up sometimes, but fortunately, if there's a good system in place, it can be kept to a minimum. And a lot of that is trying to figure out the patients that need sort of direct handoffs between the pediatric and the adult provider versus those that the transition actually is pretty easy and it's kind of a referral up to the adult medicine side. And sometimes that really boils down to how well the disease is controlled. If the disease is difficult to control or has been difficult to control, those are patients that oftentimes that Nick will pick up the phone and give me a call, and we will talk directly about what is transitioning need to look like for that, recognizing that handing the baton is sometimes handing medications and medication changes in the midst of things. And so there's a difference between care that is in patients that have controlled disease or potentially uncontrolled or difficult to control diseases. That's where communication actually is the most important when it comes to the adult and pediatric providers. Mistrust is usually just a system of not knowing much about where they're going. Sometimes you don't know exactly who the adult gastroenterologist that you may be sending the patient to on the pediatric side of things. And so that comment is really more of the not knowing your own system or not knowing the system that they're going to sometimes can provide some anxiety within the system. Adult providers on my side of things, we may not have a lot of experience with adolescents and at certain either development or techniques and interactions that occurs with adolescents. Because again, I'm an adult physician, but the more, if you go to someone that's seasoned, or if you have the opportunity to be referred to an adult physician that is seasoned and dealing with and working with adolescents and young adults, oftentimes that transition can be easier. And last but not least would be the adult provider's lack of knowledge or comfort regarding the pediatric disease states. Because I will say eosinophilic esophagitis is definitely different in pediatrics than it is in adults. And so this is something that at least Nick and I have a good rapport about, and we recognize that those symptoms can change over time. And so working through the changing of the symptoms and changing in medications and how things are being addressed is something that is important on our side of things. All right, next slide. And 2 slides on systematic barriers. And this is, I mentioned earlier, the lack of exemplary transition programs or detailed program descriptions on how to do this well. Nick and I are here hopefully trying to get information out, not only to the communities, but also to the medical communities on at least recognizing that there is an effort being made to try to do this well, and because we know this is better for our patients. This is better for quality of life. This will help keep limiting fractured care that can develop if there's not a good system in place. Funding is quite tricky with this, especially in adult medicine where there's not a lot of extra funding that goes into having a transition coordinator and having all sorts of extra educational materials and sometimes administrative support to allow scheduling to occur easily. Transition coordinators are oftentimes, if they do exist, they're oftentimes on the pediatric side, and they may be coordinating multiple disease states, whether that's inflammatory bowel disease, or whether that's EOE or other kind of chronic problems. But oftentimes that funding can be very difficult, and each system may or may not have that challenge brought to them. And the last thing is absence of a written individualized transition care plan. And this is, again, really mainly necessary if someone is not doing well. And this is oftentimes where just good communication between the pediatric and adult providers really can go a long way as we're trying to figure out, all right, this is what I'm thinking next with this patient. This is what's already occurred. This is where we're trying to go next. And doing that well is something that we can do to try to get through that particular type of barrier. All right, next slide. Reimbursement for transition services is actually very minimal, if any. And so because of that, that is a barrier that we as hospital systems have to try to think through for us to provide the best care to our patients. Can we devote services and finances towards doing this well? Can we try to provide that extra support that may not have a financial incentive behind it specifically, but recognizing that that's the best thing for our patient? And that's a battle that we do face and fight in adult medicine. Insurance coverage and changes is something that is a big deal, especially as patients get above age 25 and they may no longer be under their parents' prior insurance. But there are transitions of patient insurance that occurs all the time as caregivers may transition jobs or change jobs around or life events occur. And so we have to think through those things well to make sure that we can maintain care for our patients. But those are barriers that come up frequently that have to be addressed. Abrupt transfer without preparation is a really tricky point. Fortunately, this is very rare in my world. Actually, it never really occurs, especially with our relationship with Children's of Alabama. But sometimes patients will kind of show up on the adult doorstep from an outside gastroenterologist, and there's really very little records, or we're not even sure what medicines they may be on or have been on before. And so sometimes we can be starting over from square one to try to refigure out, all right, where do I need to go? Does the patient need to be scoped again? Do we need to reassess disease status? And so really that boils down to good communication being the paramount of the transition between providers. And as Nick said earlier, each patient and caregiver and family and then their disease state is different. And so we need to be flexible to be able to address the needs that occur in each individual dynamic, both the medical dynamics that are there, the family, and then the socioeconomic dynamics that occur with different insurances and medicines and things of that nature. So those are big barriers that we come in contact with all the time, but we're also, these are not new things to us as providers. We are adept at trying to approach each of these and work with each family at how do we approach this well. All right, next slide. So to summarize kind of what Nick and I have been talking about and to reiterate, first off, eosinophilic esophagitis and EGIs, they are chronic diseases. These are things that it's our job to help each patient and caregiver understand that it's going to be with an individual for their life. But early and ongoing education is very key about that. And once we recognize that and understand that adhering to treatment strategies, whatever that is, whether it's diet, whether it's drugs, whether it's dilation therapy that ends up sometimes being necessary in adults, those treatments exist, and approaching those and adhering to those really can improve quality of life and can improve the transition as someone is going from pediatric to adult medicine. It does involve preparation, though, and that preparation, as we talked about, starts early, just involving the concepts of it, recognizing the disease state itself, and then recognizing the medicines that need to be kind of continued as you transition from one physician to the next, and whether that's just refills on medication. Sometimes that's all that's necessary and needed at my first visit, but that is something that does involve preparation on both the pediatric and adult side. And as I mentioned, barriers do exist at multiple levels, whether it's at the patient and caregiver side, whether it's on the provider side, or whether it's systematic barriers that are there. Those are all things that can be thought through and things that we address on a day-to-day basis, and that we want to be here to help out each of our families work through well. So I think that is what I wanted to get across today and this morning and afternoon. So we'll take questions.
Well, thank you so much for both of you for putting together this presentation. We're looking forward to now having a conversation with you to continue helping everyone learn about healthcare transitions. So before we open up to questions, we're going to have kind of a little fireside chat here. And then as we are talking, please go ahead and open up that Q&A tool on the bottom of your screen. Type in your questions, and we will get to those while we're talking today. Alrighty. So the first question we want to know is, when should someone start preparing for the transition to adult care? Is there a golden age that this should occur at?
Yeah, I'll take this one. I think, as we mentioned throughout the slide deck, I think it's, you're even preparing before diagnosis, right? I think just having those normal age appropriate developmental discussions with your kids and making sure that they're ready to accept the responsibilities and the needed tool kit for themselves into adulthood is a good starting place. And then at diagnosis, I think it should be an intentional, hey, this is a chronic disease. We're going to need to continue to treat this over time. And so if you're diagnosed in childhood, we know that's coming. And so addressing it, and like I said, I even start as young as my school age kids that are able to cognitively understand, like, hey, I know what a doctor's office is. I know what a disease is. Let's talk about this and make sure that you understand that I care about your understanding of what this is and how this is going to play out. So at any point along the continuum is a good time to start, but realize you're preparing all the time for this, even before diagnosis.
Is there a certain age at which a pediatrician has to stop seeing a patient?
Great question. The answer is no, and it's really challenging because there's so many contextual elements to this, right? So I'm going to try and stay above that as far as what is true here at Children's of Alabama versus your local situation may be different, but in general, know that this is a problem that we deal with as pediatric gastroenterologists, but as a pediatric specialty in general is really important. And so a lot of times there are different strategies and a continuum of strategies that kind of address this. In general, for us, I think a good rule of thumb is that at your 19th birthday, we should be making sure that we're working towards, if we're not already transitioned to adult care. Now, that's a rule of thumb. There are many exceptions. I have patients that we'll talk about a little bit later, I think, that have a lot of other chronic illnesses or developmental challenges that they need transition support that is way beyond what just a patient with EOE would need. And so we're lucky here to have a resource that's just been developed in the past 2 or 3 years, where it's a whole transition clinic that's designed to take these really challenging situations on and make this go well. Because me as a pediatric gastroenterologist can transition effectively to Dr. Callaway for my EOE patients. But if you layer on now, you have issues that need to be addressed, like, even as simple as supplemental nutrition through a feeding tube, right? That can be really challenging to layer on top of that and find out how to do that. So oftentimes we need to tap into additional resources, but we're lucky. For the most part, we have these resources, and they include things like national organizations like APFED, right? That help think through that and create that peer environment to say, hey, I have this very specific challenge that's different than what I can see in the literature, or they didn't mention that in this talk. Does anyone else have experience with that? How do I deal with this, right?
Thank you. A family is starting to prepare for a transition, they've selected who the next person is that they're going to see, such as Dr. Callaway. What are the medical records that are needed for a successful transition? Like, what documentation do they need to be prepared to take with them?
Sure, I can comment on that. I think, in general, the main things that we would like to see or that I would like to see when I'm receiving records are clinic visits, endoscopy records, and pathology. And that is so we can actually look at the biopsies that have been taken before, and that can kind of help us come up with a timeline of treatment that's occurred already, what treatments they may have been on. Oftentimes, a good clinic note is really the main thing of what we need, especially if the physician has summarized where that treatment has been. Sometimes people even put in a transition statement, recognizing that this may be the last visit that they're seeing on the pediatric side of things, and they will try to summarize what has occurred so far, the current state of said disease. And fortunately, all those medical records should be our pediatric counterparts recognize the important information and should send that stuff on to the adult side where you're being referred.
If you're not in as well prepared a system as you two have together, uh, is that something you can ask your clinician? Can you write me a letter to help my new adult provider?
I do think you can ask that question. I believe asking that question is very fair. And then also sometimes, I mean, a phone call goes a long way. I do think that as providers, we are comfortable doing that. We want to build relationships with the people that we're referring to as well. And especially if the disease state is difficult to control or has been difficult to control, it's always appreciated on the adult side of medicine to get that phone call and to say, "Hey, we've been struggling with this. We are ready to transition. This has been my plan, and this is what I'm trying to go." Because if anything, I want to continue with the trust and the relationship that's been built with the pediatric provider to kind of maintain that trust and continue that trust. And so having that phone call early can be very helpful at establishing that.
Wonderful.
And
So,
I,
thinking through all of that background that you're doing, is there a certain point that you want those medical records? Like, do you want the patient to show up with them at that first visit, or is there you want them 2 weeks in advance?
Sure. Usually they do come in advance. I will say in our system, every system's different with us. Unfortunately, the wait time sometimes, at least at UAB medicine, adult medicine can be in the months range. And so oftentimes those records will come months in advance of the actual appointment. Even more important, though, actually, is if there is a difficulty with disease state and disease control, that phone call that goes a long way of helping us figure out how do we transition a patient well. But again, we're also very accustomed to reading charts and information at the time of the initial visit and kind of putting all the pieces together. But having it in advance, especially if we have time to review that, can oftentimes help us make decisions earlier. There are some patients that I may actually want some additional or have a plan in place even before they come and see me the first time because I've had that chance to review their records and establish at least a continuation of treatment, or do we need to be going a different direction based on what I'm reading?
Dr. Jacob, would you like to add anything?
yeah, I think, the one of the hats that I wear is actually as one of our clinical informaticists here, which means I work with computer systems and the electronic medical record. And this is a really exciting time for everything related to medical systems because the tools at our fingertips are so advanced compared to where we were at the beginning of my training. I remember, writing a physical chart, my clinical note, the results, my impressions, and you can imagine the challenges of getting that kind of information to get to the right place, right? Nowadays, it's often as simple as, opening up my medical record and I can get patients information from across the world. So if they had been seen, even in pediatrics, there's transitions between pediatric institutions when people move, right? And so if someone had been seen in another part of the country on a in a system that was compatible, and most are now. They're working towards the compatibility. I can pull up their records. I can even see the pictures of their most recent endoscopy, right? So it's pretty incredible, and I think people should really, as part of this preparation, engage with the electronic medical record that you are in. Sign up for the patient portal. Look at the different things, understand it, and because you can actually probably do a better job than I can summarizing a lot of this. Because I know the facts, I know the results, but those details that are really important when it comes to, what were the challenges we were seeing? Were we really all the way compliant, or were we just partially compliant because that was a really tough year and the pandemic was going on? Those are important details that get lost, and that's where I think making sure that the patient and that family dyad is activated and know that they have really important information to share, and to incorporate into that transition is really important. So it's exciting. I think my last thought on that is that AI is really helping too. I think artificial intelligence is everywhere, including your medical record, and it becomes a lot easier for clinicians like myself to take complicated stories that happen over a year's time and very quickly summarize those in a meaningful way. One of the most challenging things for me is actually when patients ask for those summaries. I'm willing to do it, but it's very time and labor intensive work, because there's so much information there that needs to be incorporated in order to do it well. So I'm excited for the future of that. We're like, bear with us because it's still very early, but that's going to get better and better with time, I think.
Thank you both. So endoscopies are something that are very much involved in treatment and management of eosinophilic esophagitis. If someone is transitioning from a pediatrician to an adult provider, do they have to get rescoped right away?
Short answer is no, not necessarily. A lot of it really depends on their disease state, when they were scoped last, what did that show? Are they controlled or are they uncontrolled? And then what therapies they've been on. So those are the factors of things that at least I would look at to try to help make that determination on whether or not someone would need to be have another endoscopy. And again, the whole purpose of an endoscopy really is to try to assess disease state. So it is literally an assessment of how much inflammation is going on. What does the esophagus look like? Are there things that we need to improve on? A lot of that's driven by patient symptoms. And so obviously we would touch base in clinic and discuss like where the patient is at clinically and what is their quality of life with regards to their disease. And if there's any concerns that there's still active disease going on, or if we know there's active disease going on, that may push us one way or the other on at least taking a look endoscopically, but it's not required. And most patients that I see that are transitioned to me do not need an endoscopy within the first year or two if they are already controlled.
As technology continues to advance, there are more ways to be able to conduct scopes and be able to evaluate disease progression and management. Will people need to use anesthesia or be put to sleep for scopes as they transition to an adult provider if they may have previously been using some of the unsedated transnasal options?
Yeah, great question. So Dr. CaJacob and I, we have a unique experience here in Birmingham, Alabama, which is we have access to multiple different modalities to perform endoscopies. Dr. CaJacob has become an expert in transnasal endoscopy, which is an unsedated approach that he could speak more to, that allows the biopsies to be done in a clinic visit without requiring general anesthetics. On the adult side of things, there are products that allow for transnasal endoscopy to be done in the adult setting as well. Most frequently, I would say 95 to 99+% of endoscopies are probably done with anesthetic care, not under general anesthesia though, typically under what's called monitored anesthesia care, which uses a deep sedation technique that's still outpatient, that allows for safe and effective endoscopy to be done relatively quickly in the outpatient setting that doesn't have the same risk that may be associated with general anesthesia. But there are multiple different modalities, and you'll have to work with your system and your provider on what they offer to really figure out what they feel comfortable doing and what they can offer to each individual patient.
Yeah, I'll add the similar thoughts that it's hyper contextual, right? This is one of those things that you're really going to get probably as many different versions of this answer as providers that you would ask at this point. And so there are themes, and I think it's important for me, in a general concept of thinking about how am I going to approach this disease over time is one of my goals is to limit the total number of endoscopies that you need, whether they're sedated or unsedated. And so being thoughtful, having those conversations, making sure that we're answering questions when we do the endoscopies. That's where, Dr. Callaway, exactly right? Like we're not going to do a scope just to do a scope, just to establish a baseline if we've already established that baseline, right? I think we need to be thoughtful about that. And I think this is a great example too of where the future is hard to predict with this, right? I wouldn't have guessed 4 or 5 years ago that transnasal endoscopy would have been where it's at today. That it's a very well accepted procedure that we here just completed our 200th transnasal endoscopy over the course of 2.5 years. So that, the acceptance from the patient side, how well they tolerate it, was surprising to me. And there's going to be more advancements in this space, more availability for unsedated or less invasive modalities. So there's the string test that's been out there, things like that. So I think make sure that when you're having a discussion about transition on both sides, both the pediatric and the adult side, that part of your discussion in those clinic visits and as you prepare is what is available, and because that may guide how you think about choosing where you're going to go, because oftentimes you'll have choices, and depending on your preference, that may guide how you want to navigate that space.
I think that naturally transitions to a question that we received from the audience. They're looking for tips. If I'm transitioning from a pediatric to an adult GI, how do I find the appropriate, knowledgeable doctor that can support me? One question they did ask was, does APFED have a directory? So I'll take that one. Yes. Visit apfed.org and check out the specialist finder. You can search for specialists around the world who treat eosinophilic disorders. The people in that database are all self-reporting that they are providing support for patients with these conditions. And there's a number of information that you can learn about them so that you can contact and make decisions if you would like to receive care from those providers. But from your perspective, what do you suggest to people? Obviously, you have a person and a pathway that you can direct to, but I'm sure not all of your patients are local either.
Yeah, I'll tackle it first, and then I'll let Dr. Callaway go too. This is hugely challenging, but I also think it's don't be overwhelmed by it. Like, you have lots of resources. There is resources like APFED. There are resources like social media. This is a great example of where social media, I think you should have a generous threshold for, thinking about, hey, is this really true or not? But it's a great resource to say, hey, what are people's experiences with that transition, and where you're going? What are your thoughts? This is my situation, so and then rely on other resources you have. If you're in the visit with me and you ask me what should I do, and I'm going to answer you based on that context, but it's so contextual that it's hard to give a generalized answer to that, other than to say that there will be providers that are excellent and will continue to provide excellent care regardless of your situation. It's just finding those providers that can be challenging, but in a lot of cases like us, it's fairly easy.
Yeah, I'll say expertise does vary from provider to provider, and their comfort level is also going to vary. And so you'll recognize that as you meet providers for the first time, at least in academic medical centers, you can look our profiles up and you can see who has an interest in eosinophilic diseases and disorders. And so oftentimes that can help guide things. And those relationships are you typically already built in from pediatric to adult specialists, at least in large centers, large urban centers that have that. It definitely is going to be more difficult in more rural areas where the expertise and specific expertise in EGIDS and EOE may vary. But I will say most adult gastroenterologists are starting to become more and more comfortable with eosinophilic esophagitis as its prevalence and incidence continues to increase, and our acknowledgement of its existence, and it continues to grow. The other EGIDs are a little bit trickier when it comes to just mainly because the prevalence and incidence is so much lower. Recognizing and finding experts in those disease states may be a little bit more difficult and challenging.
Thank you both. Well, if anyone else who's joining us live right now has any other questions, we certainly invite you to please, again, open up that Q&A box and send in your questions. So another thing that we've talked about and hinted on today is about the fact that these are chronic conditions. And so it's something you're going to manage for a long time. I'm sure you have many young adults and teens ask you, do I have to take these medications forever?
Short answer is it has to be managed forever. Whether or not it's medications is something that I do bring up a lot, because what works for someone at 15 may not be the same thing that works for someone at 20 versus something that works at age 30. I couldn't imagine a dairy-free diet when I was 16-year-olds and at 16 years old and drinking milk all day, every day, because trying to grow and bone growth and whatnot. But thinking about that at age 30 or 35, it may be something that I'd be much more willing to consider. And it's a very proven and effective non-medicinal way to approach eosinophilic esophagitis or food elimination diets in general. And so one size does not fit all, and it also can vary throughout someone's lifetime. So the answer to that question is that it is a chronic disease, and so some type of management is going to be needed for life, but that may vary patient to patient.
Yeah, and I'll add to that I think it's amazing to me, having now done this for 12 plus years, you see those stories that play out, and I do see patients that even are very successful with one approach that just decide like, hey, this is not right for me right now. I've changed, right? And that's okay. Those are conversations you should have. And sometimes people even need a break, and that, as long as we're talking about that and being thoughtful about what that means, that can be okay. But I think it's right that managing this over a lifetime involves having those conversations, making the best decisions that you can based on the information that we have, and that's going to change with time. And we're going to get better at this, and hopefully, in doing so, I think a lot of people, what they come to is an understanding and realization that, hey, when I manage this successfully, I feel better. And so I oftentimes don't have to chase people and say, hey, you got to take that medicine. They're saying to me like, hey, when I don't take that medicine, I don't feel good, and I don't like that, and I want to continue to manage this in a way that's successful. So getting there can take some time, and it can be a very challenging road. But when you get there, it's very gratifying from a provider standpoint, because there's not a lot of things in GI that we have that are like that, where when it makes such a big difference in people's quality of life. I think my wife's actually an allergist, and we have conversations about this, and she's like, oh yeah, people feel great when I help them, and it's not always the case for me as a pediatric gastroenterologist. I really relish the opportunity to make people feel great and have that be so impactful in their lives.
Well, thank you both for all of this. You've talked about how to be able to make things go smoothly, all the tips for success when going through the transition. Do you have any tips for when people run into challenges when going through a transition of care?
I think from my side, part of the transition planning for me is to let them know that it's not a cut and dry event, right? I'm not going to cut the cord and you're forever on your own to figure this out, right? So I have some patients who even at, um, you know, 24, 25, and we transitioned a few years back, will call me and say, hey, I'm having this issue and I need help. And I'm happy to do that. It's not going to be a clinic visit and a scope, but at that point, but it is going to be, hey, how do we navigate this? How do we find success here? So I think realize that you still have resources. If it's not going well, it doesn't mean that it's not going to continue to go well. Continue to engage your resources, make sure that you're thinking through this, and realize that there's opportunities to improve the situation if you need to.
Wonderful. Well, do either of you have any final words of advice for all those either preparing or going through transition of care?
Just want to make a comment that, again, there is work being done in this space. Dr. CaJacob and I are two of the providers here in Alabama that have an interest in this, and this is, hopefully you'll find duos and then groups of physicians that are doing this all over the country that are really we want to improve the lives of our patients, and know that we want you to transition well just as much as you want to transition well as you're transitioning to adult medicine. So.
Yeah, we care deeply about this. This is an important aspect of making sure that we're and even beyond that, we're thinking through, like, how does the transition incorporate into other aspects of care? How do we make sure that we're appropriately getting people diagnosed in this critical period where they are transitioning, because that can be a really difficult place to be. So oftentimes that it includes picking up a phone and saying, hey, I got this person that's an adult essentially, but they're here in my clinic. I could scope them, but is it more appropriate for you to scope them that first time to establish a diagnosis? Because if I scope you when you're 19, and then you need to immediately go to a transition, am I setting you up for success, right? So there are aspects of this that apply to the care that we provide, and we care. Other people care. It can be challenging. If you're having challenges, they're not forever, and keep at it, because this is something that, when done right, makes a big difference in people's lives.
Well, thank you both so much for your time today, for helping to educate people and sharing all of the insights that you have learned along the way. Thank you also to our education partners for their support of this webinar series, including AstraZeneca, GSK, Sanofi, Regeneron, and Takeda. Our next webinar is going to be about living with EGIDS, and it's going to be from the perspective of a pediatric GI. So please join us on January 21st. You can register at apfed.org/webinars. You can also continue to learn more about eosinophil-associated diseases by subscribing and listening to our podcast, Real Talk Eosinophilic Diseases. In the latest episode, we talked with Dr. Evan Dellin and Dr. Elizabeth Jensen about predictors of not using medication for EOE. You can find the episode at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more. We also encourage you to save the date for our annual patient education conference. We are headed to Denver next summer. So we hope to see you all next July for that. You can see more information as it's released at apfed.org/conference. And for the rest of the month in December, you can also continue to access on-demand content from our 2025 conference. So those session recordings are available to continue to watch through the end of the year. Finally, we encourage you to continue discussion started today on our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again, both Dr. Callaway and Dr. CaJacob, for joining us for today's webinar series. We really appreciate your time. If anyone has a question that didn't get answered today, please email mail@apfed.org, and I hope everyone has a great afternoon.